we will invite Prof. Hsiujung. It's actually a funny situation. I was invited to her workshop in Taiwan, and then I had a stupid question to ask her, and then we had a discussion, and then now she's here with us in this One Health forum. So I think we will see that she is a deputy director of the National Institute of Infectious Disease and Vaccinology in Taiwan, and also a general secretary of the National Disease Bank in Taiwan, especially Mycology Reference Center, and she is a creator of the Candida tropicalis database. So we have around 40 minutes for fungal infection and in One Health situation. So the floor is yours, Prof. Hsiujung.
Yeah, terima kasih. That's the only one I know how to speak. And thanks for inviting me again to share our laboratory result about the fungal infections. And this is one of the example to show you One Health issue, how the fungal infection lead me to involve in the One Health. And this is how to pronounce my name, Hsiujung. Yes. So this is the outline I'm going to give today, and I'm not going to read it, but just go through it one by one. So this answer if you get the infectious disease, what will happen? You go to the hospital. The first thing is, as I say, it's very important to have the right diagnosis. For example, whether it's infected by bacteria or fungi or viruses. And how to do that is, I would like to emphasize, it's very important to do the epidemiological study locally, because you have to know what's the situation in your own area. The reason is that when I go back to Taiwan in 1999, I want to conduct the surveillance, and people say, oh, come on, the United States or Western country have done that. Why should you bother to waste money to conduct the epidemiology study? Then I say, well, my job, I was hired by this mission, so I have to do it. So after we do it, later I will tell you, we identify one of the issue specifically in Taiwan, then later on is in Asia. So that's why, and to do the surveillance, you will know what kind of the susceptibility pattern in your area. So for example, if your patient is come to your clinic, you can say, wait, I have to get the laboratory result in 2 days, then I give you a prescription. So that is how we prescribe the medicine correctly, smoothly, is because we have the epidemiologic data. We know what kind of bacteria is susceptible to what kind of drug locally. So when you have the right medicine, are you home free? No. Sometimes you take a medicine, then there's the microbial will have the mutation 1 to 10 to 6. They have one mutation. So somehow the mutation will have some of less successful strength. Then when you use it, then it may become resistant strength. Then, you have to change it to another medicine, even though at the beginning, it is the right medicine. And the worst part is you got the wrong medicine. And then another one is actually you obtain the drug resistance from the outside environment or food or air. That's then you got the resistance. You have to change the medicine again. So that is one. And the One Health, I don't have to emphasize more. But I want to just say one thing is I put a plant in addition to these 3 parts. Okay. So why? Let me tell you a story. So this is the cause of death in the world in 2021. And the red arrows indicate the death caused by infectious disease. And for example, COVID-19 and TB and HIV. In TB, for example, every year is 1.2 million deaths. And if I say TB, I think everybody will not say, yes, I know TB. But how about the fungal infections? So as I said, this is just like an example, tip of the iceberg. If you don't look for it, doesn't mean there's no problem at all. Just because we don't know there's a problem. So that's what I want to emphasize it. So what kind of patient will get the fungal infection easily is because most of fungal pathogens are opportunistic pathogens. So in the old day, because there's not many high-risk populations. Why? Because the high-risk population including the immunocompromised patient. So for example, AIDS, chemotherapy, or those people. And before that, those people may die before they have the chance to get infections. But now technology and the medical care, so they prolong the life of them. Then they will have the immunocompromised status, and then it becomes easy and the risk population to be infected by fungal infection. And also, if you use invasive hospital procedure, you will introduce some of the pathogens, and also you got the antibacterial antibiotics. Why? Because you use broad-strain antibiotics, you kill all the bacteria, including the good one. And then the environment doesn't have the competitor for fungus. Then finally, the fungus have a chance to grow, and they will cause a disease. So the high-risk population increased, so the prevalence of fungal infection increased. Here's a number. About 6.5 million people are suffering from invasive fungal infections. Among them is about 2.5 million deaths directly caused by fungal infection. This fungal pathogen including the yeast or fermentous mold, and all the fungal pathogens. And so, as I mentioned, 1.2 million deaths caused by TB. This is almost twice more, but not many people know. That's why my job is everybody invite me. If I have a chance, I just come because I want everybody to know fungal infection need more attention. And in Taiwan, we have the conduct. This is a yeast pathogens, including all different kind of species, but it's way higher than other bacteria. So, but if you cut the yeast to the Candida, this all red one is Candida albicans or other species, then you know it's compatible to bacterial infections. So when I come back to Taiwan in 1999, so the main mission is to monitor the trend of species distribution and the drug substance of yeast pathogen in Taiwan. So we conduct the epidemiological study of T-cell rate every 4 years. And this collection criteria is published. If you like, you can read. And so basically, we have the 4 years, the same criteria, and the hospital actually is almost the same set. You don't change hospitals because they may have a different data. Then you don't know it's because you change the hospital or it's the real trend. So here is antifungal drugs. And if you're interested, you can read more. So we just have a different kind of antibiotics, antifungal drug. And one I would like to say is a cell membrane synthesis inhibitor, Hsiujung. Hsiujung is a drug for the invasive fungal infection. Hsiujung is the only drug can take orally. So if you know what's the difference by orally or the injection, because orally you can be home. You don't have to be hospitalized. I don't know in your situation, but in Taiwan, if you had to get injection, you had to go to hospital. That makes huge difference. And this is a drug, only drug type of drug can use orally. And this is just, I love this kind of the slide. That's I just show you different color represent different type of drug, and this is the year how they developed, just for your reference. And by the way, you don't have to take a photo or anything because this slide will be available to the organizer if you need it. But in the PDF file, you see, if in the other file, it will change the pattern. So if you like, you can ask for it. So now we do the susceptibility test, and that's all different kind of common Candida species. And there's several facts about this surveillance. First, Candida albicans is always the most prevalent one in whole wide world. But in the 20 years ago, it's 80% of is the disease caused by Candida albicans. Now it's about 40 to 50%. So it switched from non-albicans species because the drug use, the select for more resistant to the drug. That's a non-Candida species. So one of these is Candida krusei. This is intrinsic resistant to fluconazole. So if you diagnose Candida albicans, basically you don't use the fluconazole at all. And this one is Candida albicans that I would like to bring your attention is first, you can see is Candida albicans is number one non-albicans Candida species cause disease in Taiwan. And secondly, you don't have to really read the number, but you see the red things. Candida albicans has more higher resistance rate than the other Candida species. Okay, these two things. And this one, I have been conducted for many, many years. It's so puzzle to me is that in 2002, there's no resistance. And then 4 years later, it's high resistance. And 4 years later, there's almost none. You know, the yes and no, yes and no. And it's very puzzling. But after 2014, it always have the red color, always detect the drug resistance. And then we would like to know is whether this drug resistant isolates among these 20 years are the same genotype, or each 4 years is a different kind of Candida albicans causing the disease. So, one of the methods called multi-sequence typing, because you only need to have 6 genes, and total is about 2,600 base pair of the sequencing. You can compare the genotype. And that's what Madhuri said. I'm the curator of this Candida albicans MLST. Okay, then that's what we found. To our surprise, the resistance strain after 2014, they're almost the same as CLAD4. It's belong to one genotype, and it's CLAD4 among these 3 surveillance. And before that, there's a resistant one too, but it's not belong to CLAD4. So we have to know what's happening, why the CLAD4 is so persistent after 2014. And this is always, I would like to know is what is in your area or your country. Do you have a CLAD4 drug resistant Candida albicans too or not? And if you're smart, you say, come on, 2,600 base pair, and you can tell whether they are same genotype or not. I don't believe it, of course. So we do the whole genome sequence. So then the whole genome sequence also say the CLAD4 is very closely related. But whole genome sequence is very expensive, right? So after we prove that, nowadays we still use MLST to do it because it's cheap, easy, fast. So this is the drug resistant mechanisms, and you can tell it's a different kind of resistant mechanism. And there's a lot of reviewer, but I just want to show you is one is you don't let it get in. If it get in, you pump out, and or you mutant the target, or you overexpress the target, or you bypass request of the target, or you have something to disrupt the drug. Okay, so I'll just tell you that is because later I would like to know is why CLAD4 is so persistent. What's the characteristic of this species, this genotype? And then I would like to show you is this is busy slide, but it's color code. So here is a susceptibility. Whenever it's a R, red R means it's resistant to fluconazole. Okay, and then this is a CLAD. From here is a CLAD4, and there's other CLAD. Then the one thing is very obvious is ERG11 is the drug target. And you can see from the CLAD4 is all red because the target is mutant. So you know this is a mechanism contribute to drug resistance, but other resistance is wild type. In addition to that, Candida albicans is diploids. Diploid means they have 2 chromosomes. One chromosome of ERG11 is wild type, because the wild type ERG11 is always better than the mutant one for the Candida tuberculosis to growth. And another copy of chromosome, they have the mutant ERG11. And to my surprise, actually, I have to say, 10 years ago when we found it, I don't even know this is true. See, because that chromosome have multiple copy of mutant. Okay, so for example here, the one copy is wild type, and another copy, the number is represent a copy of ERG11, mutant ERG11. The height is one will be go 9 copy, just copy, and it's a mutant. So the drug will not recognize it. So this strain can be resistant. So you say why they have one wild type, one mutant? This is made the CLAD4 very suitable for the environment. With the drug, they switch to a mutant part. Without drug, they switch back to the wild type part. So that, and also lots of the resistant strain, they have some growth defect. Because, for example, the professor said the resistant gene in bacteria. Because, you know, if you believe evolution, they always choose the best genotype for the environment. If you have mutation, means they all, in order to survive the stress, they have the mutation. So most of the mutation strain have the growth defect. But for this CLAD4, in the laboratory condition, they go as well as the wild type successful strain. Okay, that's one thing. So then that makes the CLAD4 become so persistent, so successful, so suitable for the environment. So then is why it goes like that. There's two possibilities to let the CLAD4 become resistant. One is what I always say is if the patient take a drug, they may develop a resistance, or they got the resistance strain from foot, air, or hand, all the possibilities. So in order to distinguish these two possibilities, so I investigate whether the patient infected by resistant one has treated by other type of drug in clinical. So what we did is we review the medical charts of those patients. And to our surprise, 2/3 of patients did not use other drug 6 months before they collected, within 6 months. So another fact is that the CLAD4 resistant tuberculosis isolated from all regions in Taiwan, not particular one area like is outbreak or something like that. It's all over the Taiwan. So this is a fact. With other drugs were used in human, animal, and the plants. And also about 80% of plant disease were caused by fungi. And then it's about 150 tons of other fungicides used in Taiwan every year. 150 tons, you know, when it go blah, then we all die. And so in these effects, I think it's at least some other drug were not selected within the patient. Maybe it got it from the environment or other places. Oh, I'm sorry. What did I do? So we conduct the surveillance in the environment. So we go the arches. So the purpose is whether other resistant tuberculosis CLAD4 exists in the environment. And also is whether different pathogens have a different preference between human and the environment. So we do we divide the one farm to 5 different areas. We collect the foods, soil, and the water. And we also collect the unpinned hand and the oral rinse from the farmers. And I also asked the farmers, say, did you use other fungicides within 1 month before I collect the sample? So I always collect the sample, the food, ready to be on the market. Because the thing I say is, because if the fruit contains the resistant isolates, then you in the market, then you buy it, you may eat it. So that's the criteria we did. But now we do it every month with other purpose. So here is a color code. The green one is from human and the red one from the environment. So like I said, KINDAT applicants is most of them come from environment, especially is from the orals. And then the KINDAT tropicalis is highly species identified from this surveillance, and it's also most of them from the environment, including the KINDAT crucii, which is intrinsic resistant to the ozone. And we conduct twice, actually conduct 3 times, but the last one I haven't got the permission to tell you yet, but then I show you 2 of these. So 2012 and 2018 from the grape, papaya, and the Watts apple, and you can see the resistance rate go to 24 to 62 or 10 to 20, and the Watts apple is very less isolated, so we don't think this is statistical significance. But when you see this, the grape is the issues, and also or most of them are cleft, which is a genotype caused disease in humans. So we analyze it, the resistance rate increases significantly. And as I mentioned, I asked a farmer to give me information whether they use other fungicide before I collect the sample. And in 2012, it's about 6 farms, is 35% of a farm use of other fungicide. But in 2018, it's about 82%. They all use other fungicide. Maybe that is why the resistance rate go up in 2018. So is this just case in Taiwan? No, in Taiwan, yes, we first published, and China follow up is the case. And the cleft resistance also detected in Australia, India, Singapore, and Thailand. And in the Indonesia, recently their publication is say drug resistant one, but they haven't determined the genotype yet. And the Japan also has the drug resistant. Both of them haven't detected the genotype, but I assume it might be the correct fault. So, yeah. And we do the environment. Oops. Sorry about it. So then, we would like to know is how, since cleft is so predominant among the drug-resistant tropicalis, can we develop the rapid diagnosis method to find it? Yes, we have done the multi-process PCR. Then we use null-pol sequencing and do all the bioinformatic assay, so we can do 96 samples at one time. And I have a student who is a bioinformatics expert, so that actually now after we got it, my lab member doesn't need to use eyes to determine the sequence. So we have all different kind of the fancy thing, the AI thing. So then we can analyze that. So this is because we have the pattern. This is how my students write how the market and blah blah blah. So, but anyway. We want to know the first thing, the fact is cleft genotype is a predominant genotype among the other resistant. But how about the cleft itself? Is most of cleft belong to is resistant, or actually cleft half resistant, half sensitive? So we had to determine that. And we use the method we develop a rapid diagnosis. Then we found out the conclusion is that majority of ozone resistance belong to cleft, that's we know before. And now is most cleft also are ozone resistance. For example, here we have the 39 isolates and 32 are resistant and 7 successful. But among 7, 4 of them is one step toward the resistant. So means if you can diagnose the cleft, you basically can know it's infected by drug resistant isolates. So that's so as I said, we did a lot of whole genome sequence. So my student analyze it, compare the cleft and the non-cleft, whether we can use one of the genomes SMP to diagnose. Yes, to our surprise, we only need 3 SMP within 2 genes. It's I mean, sometimes it's too good to be true, because it reached to sensitivity 0.98, and the sensitivity specificity is 0.9. So when my students show me that, I say, I don't dare to publish this data because it's too good. It's almost 1. How can be like that? So then I asked him to check the Taiwan isolate and the global isolates. So now it's not just Taiwan isolate and also global. So the results like that, then I said, okay, I can publish it. So with that, he also do this kind of a fancy thing, so we can just easily to diagnose whether it's a Cat4 resistant, and so that's a way. And because there's some technology already applied for using DNA PCR to identify the species, but now is we not only identify species, we also can identify if each character class whether it's drug resistant or not. So to summarize that, we have conducted local surveillance, and we identify one issue, Canada tripicalis. And then since I'm the PhD, so I use my knowledge to understand the resistance mechanism, where is the reservoir, how to transmit. Then of course later we would like to make a policy to control it. So this is there's in addition to ozone, there's also other drug that is on the way to use both in agriculture and the clinical. So one of my job is to, as a policymaker, to think about it when you give the permission of those drugs that have the same action of mechanism, the same as medicine, and maybe you should preserve that for the medical use, to be selfish of our human being benefit. So the take-home message is, I did the patient in the TSRE and also agriculture, then we know this, then that's why bring me to One Health. So I think the clock is tickle. So we have to act faster and together. Because I show it's not only Taiwan issue, it's also Asia issue. I think it might be the issue in Indonesia too. So please, let's work together. And here, that is pesticide use in the world. And this is Taiwan. We use about 14 kilogram per acres pesticides. And here is Indonesia. You guys are much better than we, is half of the amount. So, but we still can work together and to see, because a lot of other countries, they use much less. So let's see whether we can work together to control the pesticide used in agriculture, especially the ozone one. So in Taiwan, and I don't know in this country, in Taiwan, at the beginning of fungicide, we don't label anything, just the name of the fungicides, pesticides. And the farmer just go to the pesticide store and say, blah, 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 then they give you there. So one day I visit my professor in the university, and he gave me very, very, very expensive herb medicine called linzhi. I don't know. Anyway, and he said, test some. I said, oh, that's expensive. How can you help? He said, because I saved one tree for the millionaire, and that tree was then $1 million NT. And I said, how can you save it? He said, because that tree was infected by bacteria, but the drug store give them the drug for the herb, for the grapes. So of course it's not cured. So when I diagnose, I change the pesticide, then that tree go happily. Therefore, he sends me with this very expensive Chinese medicine. Okay, so this is an example, because the farmer, they don't really know what it is. And so we propose on the package of the pesticide, at least you should label some like action of medicine or mechanism or what kind of target. Is that for the insect or that is for the herb or that is for the fungus, right? So finally, in August of 2019, our government changed the regulation of label of the pesticide. I mean, the package of the pesticides. So this is F, responsible fungicide, I stand for insecticide, and H, herbicide. So at least the farmer know what kind of the pesticide they used. And it's even more important is they have the action of the mechanism of action of the drug. These three, F is fungicide, these three represent other fungicide. So for me, it's very easy to communicate with farmer now. Actually today is my colleague went to my collaborator farmer to collect the samples. So I can just go to the farmer and say, would you please not to use F3? If you use others but F3, I pay for you. However pesticide you use, I pay. And they're very happy. And they know how to do it. F3, no F3, no F3. Then that's so easy. So this is only one action can make things very easily. Then you say, how long did it take us to make a government to make announcement about the regulation of the label? 30 years. 30. You know, for people like us, it's come on so easy. And but you know, when you go to reality, it takes 30 years. But you know, don't give up, because if you give up, it will not happen. But we just push. Finally, you know, people, I mean, our government do it. So this is acknowledgement. So we have a TISA hospital, of course. They are very kind to collaborate. You know why? Because we only pay very, very little money for them to collaborate to help us. And they have been helpful since 1999. And this year is the year we collect again. And we have, I'm sorry. We have the Steel Committee. Steel Committee is good is because my founder director going to retire many years, maybe 20 years ago. And he was very powerful man, you know. Then whatever he said, people will say, okay, yes, right? But he retired, become the little person like us. Whatever we say, nobody will say, oh yes, no, So before he retired, I went to his office. I said, you know, you're so selfish. You enjoy your life and you put us in a difficult situation. And he said, okay. Then I formed the Microbial Infection Laboratory Steel Committee. Okay, those members are all the very powerful person in Taiwan. So we have the backup. So then we report to them every year. What's the situation? How to do it? And is this a collection criteria okay? And they say okay. And including this one, it has the same last name, so it's very nice and helpful. And he is a military of CDC now. So, you know, he know everything about what I did. So it's very easy. Why in Taiwan I can put a plant in the one house? Because I keep brainwash him. And now he speak for me, right? So then yes, I say this is so important. But if I said it, people say, oh yeah. But the director of military of CDC, he said it, everybody said, oh yes. So that's why last year I can push the government to add the plant in the big project. Last year we have the huge project to support One Health research. So finally the plan was stick out Otherwise, before that, I didn't say human or animal or ecosystem is not important. They are very important. But I just want them to remember plant section is also important. So finally, they take my voice because I speak very loud, right? Blah, 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 blah. So then finally, they take my voice and they put the plant. And NHI, if you had chance to visit NHI is very, very unique research institutes. It's a mission-oriented research institutes. Because the epidemiology I did is impossible to conduct in everywhere, because you have to do it every 4 years, and without the publication, publication is not the major issue. To do the local epidemiology is the mission for me. That's why we can do that and keep doing that. And also is NHI have the A Research Institute and other research divisions. They have all different kind of experts. So for example, these two are bioinformatical persons. At the beginning, we do the whole genome sequence of 2 diploid of a chenotype colony. They even cannot assemble it. Because the 2 chromosomes, I can tell is A chromosome or B chromosome, blah, blah, blah. So we have the bioinformatic person who really work hard with us. So we can solve the problem. And this is my colleague and who do the null-pol sequencing. Okay. And sometimes you have to do the good thing without selfish purpose. But later on, it's payback. You know why? Because when I was the deputy director, I give myself a job. I say, okay, now what should I promote? So I promote the null-pol sequence in my institute, and I would like to persuade the real-time surveillance of antimicrobial resistance of microbials, because now it's a sequence year. You had to catch up. You know, not to say the genotype or GATC speaks everything, but it's very helpful to predict. So at that time, maybe 12 years ago, I pushed that and I support that. So then my colleague is, it got only one center called Excellence Laboratory of Null-pol sequence, and given by the null-pol sequence company. So we are very, very good at that. And this is also bioinformatics, because sometimes my staff analyze the data and say, oh, this is significant. But I was so worried. Oh, time's up. Okay. So anyway, and this is for agriculture, and it is funded. So thank you again, and thanks for collaborator. And I want to say this actually is the character of Chinese. This is a single. But if you put 2 single together, you will not feel lonely. So that's why we work together. And that's it. Thank you.
Thank you, Prof. Hsiujung. Now we know that not just human or animal, but plants are also important for human health and infection, not just by bacteria, virus, but also fungal. So I think we have 10 minutes of your Q&A. So anyone in this room would like to give a question to Prof. Hsiujung, raise your, which one?
Okay, thank you for your insightful presentation, Prof. You saw that fluconose resistance in Candida tropicalis has increased over time. From a laboratory perspective, what is the most important step we should priorities to prevent antifungal resistance, improving diagnosis capacity, expanding susceptibility testing, or strengthening molecular surveillance? Thank you.
So what is important for laboratory? One is to diagnose the species, or to know whether it's drug susceptibility. And the third one is molecular, the genotype. Okay. So for me is first, the 96 well thing. So you have to know what your enemy is. So definitely you have to identify it first. Now identify is very easy. So they are have the corn agar. You can tell the color of the colonies. But you also can do the simply PCR of ribosomal DNA. That's also within like a day you can do it. And the susceptibility testing is for some laboratory, they even didn't have an established method yet. Even in Taiwan, we don't have, not every lab can perform the susceptibility test like the bacteria. So, and for us, it's nice is we have we are the reference laboratory. So we do the surveillance. Then we tell the whole community, if you find this species, you have to be careful, see whether it's resistant or not. So for us, it's very simple. The Kusi, we know definitely you don't use a flucloxone. For the Canatropicalis, you know it's about 10 or 20% is resistance. The other species are okay. You don't have to worry too much. So that is a key point of our local epidemiology. So that, but for the Western country, I don't know in this country, Canada gubbata is one of those issues for flucloxone. But for us, luckily, it's okay. But it's gradually increase resistance. So the epidemiology is important to tell you what's the pattern here. Then everybody will know, oh, in my country, which drug I can prescribe and all those things. And the molecule genotyping is when you have a resistance, then you want to know whether it's outbreak or whether it is circulate in the country. So that it will be after you know the resistance is an issue in your area, then you do that. And of course, if you want to have a publication, that's another, is just for your curiosity of science, that's okay. But for the benefit of patient, the genotyping is not so important. So in my lab is we develop a method to do the ID and the genotyping at the same time. So that is that's what we did. Yeah.
Okay, thank you. The other one that raises the hand, that one. State your name and where you come from.
Hello, my name is David. I am from Palu in Central Sulawesi. Okay, thank you, Prof. Hsiujung. Okay, in your recommendation, your research recommendation is use the different kind of therapy for plant, animal, and human, right? Okay, how if we just have one drug of choice of the therapy for human and animal? Okay, in the case of the cystosoma, we just any one therapy is talk about praziquantel. I need your perspective from One Health approach. Thank you.
Yes, I have to say is we are human beings. Huh? We are not more important than any other beings. Okay, so in case it's only one drug for plant or animal or human, I think they should be used for all of them. But what I say is for the agriculture, for example, let's guess how many % of the fungicide you use go to the target. Do you guys know? If you use 100 gram of the fungicide, then you spread on the farm, how many % of that really go to your target? Want to guess? 1 to 10%. So 90% of that actually doesn't go to a target. They just in the environment, you know? So for me, if that is one drug, for the animal, it's easy. You just go to the animal, right? You don't, unless it is a fish, you go to the pond or something, right? So you have to use it, but use it smartly. Not like not like a spread like that, right? You can maybe inject in a disease area. That's for plant. But for the animal, I think if it's sick, that's the only drug we should use it. So I didn't mean that you should not use for ozone. I graduated from Department of Plant Pathology. So when I present my data to my steering committee, who are all the MD, right? He said, Hsiujung, go to agriculture, tell them not to use ozone drop. I said, no, because the farmer want to harvest their crop to survive. You can, but I will tell them, don't use it for the prevention. You can use other different drug for prevention, right? But when it's really, really disease, that's the only drug you have to use. Please use it. That's why I go to the farmer. I say, actually, that's real. I say, can you divide your farm to two parts? One is ozone-free. One is whatever you used to use. But if you think the experiment one, the ozone-free, it's not good anymore. I have to use ozone. Call me. Then please use it and recall it. Because if you want to persuade someone collaborate with you, you can't let them not to have a benefit, you know. They have family to raise. So I say, if everything's okay, please do not use ozone. But when you find out you can't do anything to prevent, to treat the disease, go ahead, use ozone. Then we will, after this thing goes, then we start again. You know, so this is a way to respect all the beings, you know, not the animal, plant, all those things. Yeah.
Okay. All right. So, does anyone in this? Oh, yes, one more.
So on the walking, seen about it, 150 tons of fungicide. You know, it's only very few go to the target. So the reason I just want to tell the government not to use so much ozone fungicides. And you just rotate it or reduce it, not completely stop. Because if you know, how to make the policy work is you have to generally do it. Because the farmer will not accept it. I went to so many farms. If elder one say, I have more experience, I don't want to listen to you. So my target is a young generation because you can communicate. But if the young generation goes well, then the old generation sees the neighbor, maybe he will change. So you have to find the right target to work with. Okay, sorry.
So, thank you for the opportunity. I'm Asha from North Bali. I'm a medical student at second semester. So a while back, I was learning about fungi in my class. And then I just read that there was a report about a case of coccidioidomycosis or valley fever in Taiwan. So how did the medical community there respond to the emergence of this fungal disease, and which is usually found only in desert regions? Is there a specific program or centralized database that funds intensive research or addresses the spread of fungi?
Thank you very much. So this is belong to biosafety level 3 or 3 plus or 4, for 3. So in our institute, my government, when COVID happened, and we realized we don't have a national infectious disease bank collect the very important microbials. We are only focused on whatever we surveillance, but we don't have the national data bank. So the government just asked NHI to establish the National Infectious Disease Bank called NIDB. I happen to be in charge of that. Okay, so after that we built a building, and we have a BL3 laboratory. Unfortunately, not finished yet. We are going to finish by end of this year. We can operate next year. But for the biosafety level 3, we do have another laboratory at NHI. So we do have a meeting about that part. So we say, should we study that carefully? Yes, we prepare that. So we do an analyze. I say, well, first we have to use BSS3 laboratory. You can ask other lab to work on that. So the first. So if the government really asks NIDB to do it, we have to borrow the BSS3 lab next door to ask us to use it at first. That means if government really want to do it, we can do it because we have a BSS3 facility first. And second, we happen to have the expert, my colleague, who is more expert. So she prepared that, and actually, few months later, she gonna present how to react this in Taiwan. So we have the person who can do it. Like NIDB, I have to train at least 2 people has the experience to handle BS3 microbials, and I have to train another 3 people on the class. Not really doing that, 3 people. And I also went to the class like this for 3 days. So then we are prepared for that. Not only in this species, other viruses too, a lot of other viruses. So we have prepared for these things. So we have this one of the center that we can do that. But be careful, right facility. Because we don't, and also that is not very common in Taiwan. So we say if this is just one case, let's just prepare it. Don't really make a big deal. If the second come, then at least we are ready to do it. That's our action now.
Okay, I think the time is up. Thank you once more. Give a round of applause for Professor Hsiujung. And at the end of this first session on today, I'd like to not round up actually, just giving a summary on how important that emerging disease, fungal infection, and also the health implementation is quite important. And of course, how we have to interact with interdisciplinary to to respond to One Health situation in our countries, not just Indonesia, not just Taiwan, and how we can make that as one method to develop a policy and helping us to prevent further infection or emerging disease. Okay, so this is the end of this session. I'd like to say thank you very much for the attendance on this room and also on the online. Sorry that we cannot accept more questions because of the time. So I think this is the end of my session. Thank you very much for the attention, and I will give this back to the Master of Ceremony to present more of the information on lunch, I think. Thank you very much.